reproductive system consists of organs that function in the production of the offspring. The female reproductive system produces the female reproductive cells, which are the eggs or ova, and contains an organ called the uterus, in which the development of the fetus takes place. The male reproductive system produces the male reproductive cells, called the sperm, and contains an organ called the penis that deposits the sperm within the female. It is important to have a thorough understanding of the anatomy and physiology of the male and female reproductive systems to be able to assess the health of these systems. The female reproductive system is composed of both external and internal reproductive organs. The external female reproductive organs collectively are called the vulva, which means covering in Latin. The vulva serves to protect the urethral and vaginal openings and is highly sensitive to touch to increase the female's pleasure during sexual intercourse. The structures that make up the vulva include the mons pubis, the labia majora, the labia minora, the clitoris, the prepuce, the structures within the vestibule, and the perineum. The mons pubis is the elevated, rounded, fleshy prominence that exists over the symphysis pubis. The skin of this fatty tissue is covered with pubic hair after puberty. The mons pubis protects the pubic symphysis during sexual intercourse. The labia majora, also meaning large lips, are relatively large and fleshy and are comparable to the scrotum in males. The labia majora contains sweat and sebaceous or oil-secreting glands. After puberty, the labia majora are covered with hair. The function of the labia majora is to protect the vaginal opening. The labia minora, or small lips, are the delicate hairless inner folds of the skin. They can be very small or up to 2 inches wide. The labia minora grow down from the anterior inner part of the labia majora on each side. They are highly vascular and abundant in nerve supply. The labia minora lubricate the vulva, swell in response to stimulation, and are highly sensitive. The clitoris is a small cylindrical mass of erectile tissue and nerves. It is located at the anterior junction of the labia minora. There are folds above and below the clitoris. The joining of these folds above the clitoris forms the prepuce, which is a hood-like covering existing over the clitoris. The junction just below the clitoris forms the frenulum. A rich supply of blood vessels gives the clitoris a pink color. Like the penis, the clitoris is very sensitive to touch, stimulation, and temperature, and can become erect. For its small size, it has a generous nerve and blood supply. There are more free nerve endings in sensory reception located on the clitoris than any other part of the female body, and as such is the most erotically sensitive part of the genitalia for most females. The function of clitoris is mainly sexual stimulation. The vestibule is an oval area enclosed by the labia minora laterally. It is inside the labia minora and outside of the hymen. It is perforated by 6 openings. Opening into the vestibule are the urethra from the urinary bladder, the vagina, and 2 sets of glands. The opening to the vagina is called the introitus, and the half-moon-shaped area behind it is called the fourchette. Through tiny ducts besides the introitus, Bartholin's glands, when stimulated, secrete mucus that supplies for lubrication during intercourse. Skene's glands are located on either side of the urethral opening. They secrete a small amount of mucus to keep the opening moist and lubricated for the passage of urine. The vaginal opening is surrounded by the hymen. The hymen is a tough, elastic, perforated, mucosa-covered tissue across the vaginal introitus. In a virgin, the hymen may completely cover the opening, but it usually just encircles the opening like a tight ring. Because the degree of tightness varies among women, the hymen may tear at the first attempt at intercourse, or it may be soft and pliable so that no tearing occurs. In a woman who is not a virgin, the hymen usually appears as small tags of tissue around the vaginal opening, but the presence or absence of the hymen can neither confirm nor rule out sexual experience. The perineum is the most posterior part of the external female reproductive organs. This external region is located between the vulva and the anus. It is made up of skin, muscle, and fascia. The perineum can become lacerated or incised during childbirth and may need to be repaired with sutures. Incising the perineum area to provide more space for the presenting part is called an episiotomy. Although still a common obstetric procedure, the use of episiotomies has decreased during the past 25 years. The procedure should be applied selectively rather than routinely. An episiotomy can add to postpartum discomfort and perineal trauma and can lead to fecal incontinence. The internal female reproductive organs consist of the vagina, uterus, fallopian tubes, and ovaries. These structures develop and function according to specific hormonal influences that affect fertility and childbearing. The vagina is a highly distendable canal situated in front of the rectum and behind the bladder. It is a tubular, fibromuscular organ lined with mucous membranes that lies in a series of transverse folds called the rugae. The rugae allow for extreme dilation of the canal during childbirth and labor. The vagina is a canal that connects the external genitals to the uterus. It receives the penis and the sperm ejaculated during sexual intercourse, and it serves as an exit passageway for menstrual blood and for the fetus during childbirth. The front and back walls normally touch each other so that there is no space in the vagina except when it is open, for example during a pelvic examination or during intercourse. In the adult, the vaginal cavity is about 3 to 4 inches long. Muscles that control its diameter surround the lower third of the vagina. The upper 2/3 of the vagina lies above these muscles and can be easily stretched. During a woman's reproductive years, the mucosal lining of the vagina has a corrugated appearance and is resistant to bacterial colonization. Before puberty and after menopause, the mucosa is smooth due to lower levels of estrogen. The vagina has an acidic environment which protects it against ascending infections. Antibiotic therapy, douching, perennial hygiene sprays, and deodorants may upset this acid balance within the vagina and predispose a woman to infections. The uterus is a pear-shaped muscular organ at the top of the vagina. It lies behind the bladder and in front of the rectum and is anchored in a position by 8 ligaments. A full bladder tilts the uterus backwards. A distended rectum tilts it forwards. The uterus alters its position by gravity or with change of posture, and it is the size and shape of an inverted pear. The uterus is the site of menstruation, the implantation of a fertilized egg, the development of the fetus during pregnancy and labor. Before the first pregnancy, it measures approximately 3 inches long, 2 inches wide, and about 1 inch thick. After pregnancy, the uterus remains larger than before pregnancy. After menopause, it becomes smaller and atrophies. The uterine wall is relatively thick and composed of 3 layers: the endometrium, which is the innermost layer, the myometrium, which is the muscular middle layer, and the perimetrium, which is the outer serosal layer that covers the body of the uterus. The endometrium is the mucosal layer that lines the uterine cavity in non-pregnant women. It varies in thickness from about 0.5 to 5 millimeters and has an abundant supply of glands and blood vessels. The myometrium makes up the major portion of the uterus and is composed of smooth muscle lined by connective tissue with numerous elastic fibers. During pregnancy, the upper myometrium undergoes a marked hypertrophy, but there is limited change in the cervical muscle content. The cervix is the lower part of the uterus. The cervix opens into the vagina. It has a channel that allows sperm to enter the uterus and allows menstrual discharge to exit. It is composed of fibrous connective tissue. During a pelvic examination, the part of the cervix that protrudes into the upper end of the vagina can be visualized. Like the vagina, this part of the cervix is covered by mucosa, which is smooth, firm, and donut-shaped with a visible central opening called the external os. Before childbirth, the external cervical os is a small, regular oval opening. After childbirth, this opening is converted into the transverse slit that resembles lips. Except for during menstruation or ovulation, The cervix is usually a good barrier against bacteria. The cervix has an alkaline environment which protects the sperm from the acidic environment of the vagina. The canal or channel of the cervix is lined with mucus-secreting glands. This mucus is thick and impenetrable to sperm until just before the ovaries release the egg during ovulation. At ovulation, the consistency of the mucus changes so that the sperm are able to swim through it, allowing for fertilization to possibly occur. At the same time, the mucus-secreting glands of the cervix actually become able to store live sperm for about 2 to 3 days. These sperm can later move up through the corpus and into the fallopian tubes to fertilize the egg. Thus, intercourse 1 to 2 days before ovulation can lead to pregnancy. The channel in the cervix is too narrow for the fetus to pass through during pregnancy, but during labor it stretches to let the newborn through. The corpus, or the main body of the uterus, is a highly muscular organ that enlarges to hold the fetus during pregnancy. The inner lining of the corpus, or endometrium, undergoes cyclic changes as a result of the changing levels of hormones secreted by the ovaries. It is thickest during the part of the menstrual cycle in which the fertilized egg would be expected to enter the uterus, and is thinnest after menstruation. If fertilization does not take place during this cycle, most of the endometrium is shed and bleeding occurs, resulting in the monthly period. If fertilization does take place, the embryo attaches to the wall of the uterus, where it becomes embedded in the endometrium about 1 week after fertilization. This process is called implantation. Menstruation then ceases during the 40 weeks of pregnancy. During labor, the muscular walls of the corpus contract to push the baby through the cervix and into the vagina. The fallopian tubes are cylindrical structures that extend 2 to 3 inches from the upper edges of the uterus towards the ovaries. Each tube is about 7 to 10 centimeters long and approximately 0.7 centimeters in diameter. The end of each tube flares into a funnel shape, providing a large opening for the egg to fall into when it is released from the ovary. Cilia, which are beating hair-like extensions on cells, line the fallopian tube, as well as the muscles in the tube's wall, convey the ovum from the ovary to the uterus, and sperm from the uterus toward the ovary. This movement is accomplished via ciliary action and peristalsis. If sperm are present in the fallopian tube as a result of sexual intercourse or artificial insemination, fertilization of the ovum can occur in the distal portion of the tube. If the egg is fertilized, it will divide over a period of about 4 days while it moves slowly down the fallopian tube into the uterus. The ovaries are a set of paired glands resembling unshelled almonds that are set in the pelvic cavity below and to either side of the umbilicus or belly button. They are usually pear-colored and oblong. They are homologous to the testes in males. Each ovary weighs from 2 to 5 grams and is about 4 centimeters long, 2 centimeters wide, and 1 centimeter thick. The ovaries are not attached to the fallopian tubes, but are suspended nearby from several ligaments that hold them in position. The development and release of the ovum and the secretion of hormones, estrogen and progesterone, are the 2 primary functions of the ovary. The ovaries link the reproductive system to the body system of endocrine glands as they produce the ova or eggs and secrete in a cyclic fashion the female sex hormones, estrogen and progesterone. After an ovum matures, it passes into the fallopian tubes. The 2 mammary glands, or breasts, are accessory organs of the female reproductive system that are specialized to secrete milk following pregnancy. Each breast has a nipple located near the tip, which is surrounded by a circular area of pigmented skin referred to as the areola. Each breast is composed of approximately 9 lobes. These lobes contain the alveolar glands and the lactiferous ducts that lead to the nipple and open to the outside. The lobes are separated by dense connective tissue and adipose tissue, which also help to support the weight of the breasts. During pregnancy, Placental estrogen and progesterone stimulate the development of mammary glands. Because of this hormonal activity, the breasts may double in size during pregnancy. At the same time, glandular tissue replaces the adipose tissue of the breasts. Following childbirth and the expulsion of the placenta, levels of placental hormones, including progesterone and lactogen, fall rapidly, and the action of prolactin, which is the milk-producing hormone, is no longer inhibited. Prolactin stimulates the milk production within a few days after childbirth, but in the interim, a dark yellow fluid called colostrum is secreted. Colostrum contains more minerals and proteins, but less sugar and fat than mature breast milk. Colostrum secretion may continue for approximately a week after childbirth, with gradual conversion to mature milk. Colostrum is rich in maternal antibodies, especially immunoglobulin A or IgA, which offers protection for the newborn against enteric pathogens. The female sexual response starts in a state of sexual neutrality, and the person's sexual desire is more of a reciprocal response than a spontaneous one. Her brain coordinates a patterned sexual response cycle consisting of an increased heart rate, respiratory rate, blood pressure, and a general level of excitement. With sexual stimulation, tissues in the clitoris and breasts and around the vaginal orifice fill with blood and the erectile tissue swells. At the same time, the vagina begins to expand and elongate to accommodate the penis. As part of the whole vasocongestive reaction, the labia majora and labia minora swell and darken. As sexual stimulation intensifies, the vestibular glands secrete mucus to moisten and lubricate the tissues to facilitate insertion of the penis. Hormones play an integral role in the female sexual response as well. Adequate estrogen and testosterone must be available for the female brain to sense incoming arousal stimuli. Research indicates that estrogen preserves the vascular function of female sex organs and affects genital sensation. It is also believed to promote blood flow to these areas during stimulation. Testosterone is needed to stimulate sexual desire in women. The zenith of intense stimulation is orgasm. The female orgasm is the spasmodic and involuntary contractions of the muscles in the region of the vulva, the uterus, and the vagina that produce a pleasurable sensation to the woman. Typically, the woman feels warm and relaxed after an orgasm. Within a short time after orgasm, the two physiological mechanisms that created the sexual response, vasocongestion and muscular contraction, rapidly dissipate. The orgasm experience varies from person to person and from time to time in the same person. Some orgasms are intense, some are quiet, and some are gentle. At the completion of a sexual episode, the brain and body return to the unaroused state, which is termed sexual resolution. The female reproductive cycle is a complex process that encompasses an intricate series of chemical secretions and reactions to produce the ultimate potential for fertility and birth. The female reproductive cycle is a general term encompassing the ovarian cycle, the endometrial cycle, the hormonal changes that regulate them, and the cyclic changes in the breasts. The endometrium, ovaries, pituitary gland, and hypothalamus are all involved in these cyclic changes that help to prepare the body for fertilization. Absence of fertilization results in menstruation. Menstruation is the shedding of this endometrium and marks the beginning and end of the monthly cycle. Menopause is the naturally occurring cessation of regular menstrual cycles. Menstruation is the normal, predictable physiological process whereby the inner lining of the uterus, called the endometrium, is expelled by the body. Typically, this occurs monthly. Menstruation has many effects on girls and women, including emotional and self-image issues. In the United States, the average age of menarche, or the start of menstruation in females, is 12.8 years, within a range between 8 and 18. Genetics is an important factor in determining the age at which menarche starts, but Geographical location, nutrition, weight, general health, cultural and social practices, educational level, attitude, family environment, and beliefs are also believed to play an important part. Pubertal events preceding the first menses have an orderly progression. The larchy is the development of the breast buds. Adrenarchy is the appearance of the pubic and then axillary or armpit hair, followed by a growth spurt, and menarche occurs about 2 years after the start of breast development. In healthy girls that are beyond puberty, the menstrual period varies in flow heaviness and may remain irregular in occurrence for up to 2 years following menarche. After that time, the regular menstrual cycle should be established. Most women will experience between 300 and 400 menstrual cycles within their lifetime. Normal, regular menstrual cycles vary in frequency and blood loss. Irregular menses can be associated with irregular ovulation, polycystic ovary syndrome, weather conditions, stress, disease, and hormone imbalances. The reproductive cycle, also referred to as the menstrual cycle, results from a functional hypothalamic pituitary ovarian axis and a precise sequence of hormones that lead to ovulation. If conception does not occur, menses ensues. The ranges of normal menstrual cycles are as follows. A normal cycle length is between 21 to 36 days long, with a duration of flow between 3 to 7 days. 1 to 2.5 ounces of blood loss is normal for each cycle. The female reproductive cycle involves 2 cycles that occur simultaneously: the ovarian cycle, during which ovulation occurs, and the endometrial cycle, during which menstruation occurs. Ovulation divides these 2 cycles at mid-cycle. Ovulation occurs when the ovum is released from its follicle. After leaving the ovary, the ovum enters the fallopian tube and journeys toward the uterus. If sperm fertilizes the ovum during its journey, pregnancy occurs. The ovarian cycle is a series of events associated with the developing oocyte, ovum, or egg within the ovaries. Whereas men manufacture sperm daily, often into advanced age, women are born with a single lifetime supply of ova that are released from the ovaries gradually throughout the childbearing years. In the female ovary, 2 million oocytes are present at birth, and about 400,000 follicles are still present at puberty. The excess follicles are depleted during the childbearing years, with only about 400 follicles ovulated during the reproductive period. The ovarian cycle begins when the follicular cells swell and the maturation process begins. The maturing follicle at this stage is called the Graafian follicle. The ovary raises many follicles each month, but only one follicle matures to reach ovulation. The ovarian cycle consists of 3 phases: the follicular phase, ovulation, and the luteal phase. The follicular phase is so named because it is when the follicles in the ovary grow and form a mature egg. This phase starts on day 1 of the menstrual cycle and continues until ovulation, approximately 10 to 14 days later. The follicular phase is not consistent in duration because of the time variations in follicular development. These variations account for the differences in the menstrual cycle lengths. The hypothalamus is the initiator of this phase. Increasing levels of estrogen secreted from the maturing follicular cells and the continued growth of the dominant follicle cell induce proliferation of the endometrium and myometrium. This thickening of the uterine lining supports an implanted ovum if pregnancy occurs. Prompted by the hypothalamus, the pituitary gland releases follicle-stimulating hormone, or FSH, which stimulates the ovary to produce 5 to 20 immature follicles. Each of these follicles houses an immature egg or oocyte. The follicle that is targeted to mature fully will soon rupture and expel a single mature oocyte in the process of ovulation. A surge in luteinizing hormone, or LH, from the anterior pituitary gland is actually responsible for affecting the final development and subsequent rupture of the mature follicle. At ovulation, a mature follicle ruptures in response to the surge of LH, releasing the mature oocyte or ovum. This usually occurs on day 14 of a 28-day menstrual cycle. When ovulation occurs, there is a drop in estrogen. Typically, ovulation takes place approximately 10 to 12 hours after the LH peak and 24 to 36 hours after estrogen levels peak. The distal ends of the fallopian tubes become active near the time of ovulation and create currents that help carry the ovum into the uterus. The lifespan of the ovum is about 24 hours. Unless it meets a sperm on its journey within that time, it will die. During ovulation, the cervix produces thin, clear, stretchy, slippery mucus that is designed to help the sperm travel up the cervix to meet the ovum for fertilization. Ovulation symptoms include vaginal spotting, an increase in vaginal discharge, and an increased libido leading to more desire to be intimate, as well as a slight rise in body temperature and lower abdominal cramping. The one constant, whether a woman's cycle is 28 days or 120 days, is that ovulation almost always takes place 14 days before menstruation. The luteal phase begins at ovulation and lasts until the menstrual phase of the next cycle. It typically occurs on days 15 through 28 of a 28-day cycle. After the follicle ruptures as it releases the egg, it closes and forms a body called the corpus luteum. The corpus luteum secretes increasing amounts of the hormone progesterone, which interacts with the endometrium, preparing it for implantation. At the beginning of the luteal phase, progesterone induces the endometrial glands to secrete glycogen, mucus, and other substances. The progesterone secreted by the corpus luteum causes the temperature of the body to rise slightly until the start of the next period. This temperature remains elevated until 3 days before the onset of the next menstruation. This rise in temperature can be plotted on a graph and gives us an indication of when ovulation has occurred. In the absence of fertilization, the corpus luteum begins to degenerate and consequently ovarian hormone levels decrease. As estrogen and progesterone levels decrease, the endometrium undergoes involution. In a 28-day cycle, menstruation begins at approximately 14 days after ovulation in the absence of a pregnancy. FSH and LH are generally at their lowest levels during the luteal phase and are highest during the follicular phase. The endometrial cycle occurs in response to the cyclic hormonal changes. The 4 phases of the endometrial cycle are the proliferative phase, the secretory phase, the ischemic phase, and the menstrual phase. The proliferative phase starts with the enlargement of the endometrial glands in response to increasing amounts of estrogen. The blood vessels become dilated, and the endometrium increases in thickness dramatically from 0.5 millimeters to 5 millimeters in height, and increases 8-fold in thickness in preparation for implantation of a fertilized ovum. Cervical mucus becomes thin, clear, stretchy, and more alkaline, making it more favorable to sperm to enhance the opportunity for fertilization. The proliferative phase starts on about day 5 of the menstrual cycle and lasts to the time of ovulation. This phase depends on estrogen stimulation resulting from ovarian follicles, and this phase coincides with the follicular phase of the ovarian cycle. The secretory phase begins at ovulation and goes until about 3 days before the next menstrual period. Under the influence of progesterone released by the corpus luteum after ovulation, the endometrium becomes thickened, more vascular, and more glandular. These dramatic changes are all in preparation for implantation, if it were going to occur. This phase typically lasts from day 15, just after ovulation, to about day 28 and coincides with the luteal phase of the ovarian cycle. In the absence of fertilization, by day 23 of the menstrual cycle, the corpus luteum begins to degenerate and consequently ovarian hormone levels decrease. As estrogen and progesterone levels decrease, the endometrium undergoes involution. If fertilization does not occur, the ischemic phase begins. Estrogen and progesterone levels drop sharply during this phase as the corpus luteum begins to degenerate. The ischemia leads to the shedding of the endometrium down to the basal layer, and menstrual flow begins. The menstrual phase begins as the spiral arteries rupture secondary to the ischemia, releasing blood into the uterus, and the sloughing off of the endometrial lining begins. If fertilization does not take place, the corpus luteum degenerates. As a result, both estrogen and progesterone levels fall, and the thickened endometrial lining sloughs away from the uterine wall and passes out via the vagina. The beginning of the menstrual flow marks the end of one menstrual cycle and the beginning of a new one. Most women report menstrual bleeding for an average of 3 to 7 days. The amount of menstrual flow will vary, but averages 1 ounce in volume per cycle. The menstrual cycle involves a complex interaction of hormones. The predominant hormones include gonadotropin-releasing hormone, FSH, LH, estrogen, progesterone, and prostaglandins. Gonadotropin-releasing hormone, or GnRH, is secreted from the hypothalamus in a pulsatile manner throughout the reproductive cycle. It pulsates slowly during the follicular phase and increases this process during the luteal phase. GnRH induces the release of FSH and LH to assist with ovulation. Follicle-stimulating hormone, or FSH, is secreted by the anterior pituitary gland and is primarily responsible for the maturation of the ovarian follicle. FSH secretion is highest and most important during the first week of the follicular phase of the reproductive cycle. Luteinizing hormone, or LH, is secreted by the anterior pituitary gland and is required for both the final maturation of the pre-ovulatory follicles and the luteinization of the ruptured follicle. As a result, estrogen production declines and progesterone secretion continues. Thus, estrogen levels fall 1 day before ovulation, and progesterone levels begin to rise. Estrogen is secreted by the ovaries and is crucial for the development and maturation of the follicle. Estrogen is predominant at the end of the proliferative phase, directly preceding ovulation. After ovulation, estrogen levels drop sharply as progesterone dominates. In the endometrial cycle, estrogen induces proliferation of the endometrial glands. Estrogen also causes the uterus to increase in size and weight because of increased glycogen, amino acids, electrolytes, and water. Blood supply is expanded as well. Progesterone is secreted by the corpus luteum. Progesterone levels increase just before ovulation and peak 5 to 7 days after ovulation. During the luteal phase, progesterone induces swelling and increased secretion of the endometrium. This hormone is often called the hormone of pregnancy because of its calming effect on the uterus, which reduces uterine contractions, allowing a pregnancy to be maintained. Prostaglandins are primary mediators of the body's inflammatory processes and are essential for the normal physiological function of the female reproductive system. They are closely related to a group of oxygenated fatty acids that are produced by the endometrium with a variety of effects throughout the body. Although they have regulatory effects and are sometimes called hormones, prostaglandins are technically not hormones because they are produced by all tissues rather than special glands. Prostaglandins increase during follicular maturation and play a key role in ovulation by freeing the ovum inside the Graafian follicle. Large amounts of prostaglandins are found in menstrual blood. Research is ongoing as to the various roles that prostaglandins play in the menstrual cycle. Menopause transition or perimenopause and menopause are biologic markers of the transition from young adulthood to middle age. Neither of these is a symptom of disease, but rather a natural maturation process of the female reproductive system. During the perimenopausal years, about 2 to 8 years prior to menopause, women may experience physical changes associated with decreasing estrogen levels. These may include vasomotor symptoms of hot flashes, irregular menstrual cycles, sleep disruptions, forgetfulness, irritability, mood disturbances, decreased vaginal lubrication, night sweats, fatigue, vaginal atrophy, and depression. Vasomotor symptoms are hot flashes and night sweats. These are the most common complaints for which women seek treatment. Several therapies can be considered to help manage these complaints. Choosing an appropriate treatment approach for the management of these symptoms requires careful assessment of the risk-benefit ratio of each alternative, as well as individual client preference. Menopause is a universal and irreversible part of the overall aging process, involving a woman's reproductive system, after which she no longer menstruates. This is a naturally occurring phase of every woman's life and marks the end of her childbearing years. The average age of natural menopause is defined as 1 year without a menstrual period and usually begins after 50 years of age. As the average life expectancy for women increases, the number of women reaching and living in menopause has escalated. Most women can expect to spend more than 1/3 of their lives beyond menopause. It is usually marked by an atrophy of the breasts, uterus, and fallopian tubes, as well as the ovaries. Many women pass through menopause without many symptoms. These women remain active and in good health with little interruption of their daily routines. Other women experience vasomotor symptoms, which give rise to sensations of heat, cold, sweating, headache, insomnia, and irritability. Until recently, hormone therapy was the mainstay of menopause pharmacotherapy. But with the recent results of the Women's Health Initiative trial and the heart and estrogen replacement study, the use of hormone therapy has become controversial. Many women have turned to non-traditional remedies to manage their menopausal symptoms. Common complementary alternative medicine remedies used for the treatment of menopausal symptoms include black cohosh, dong quai, St. John's wort, hops, wild yam, ginseng, evening primrose, exercise, and acupuncture. The male reproductive system, like that of the female, consists of those organs that facilitate reproduction. The male organs are specialized to produce and maintain the male sex cells, or sperm, to transport them, along with supporting fluids, to the female reproductive system, and to secrete the male hormone testosterone. The organs of the male reproductive system include the penis, scrotum, 2 testes where the sperm cells and testosterone are made, and the accessory organs including the epididymis, vas deferens, seminal vesicles, ejaculatory duct, urethra, bulbourethral glands, and the prostate gland. The penis is an organ for copulation and serves for the outlet of both sperm and urine. The skin of the penis is thin and has no hairs. The prepuce or foreskin is a circular fold of skin that extends over the glands unless it is removed by circumcision shortly after birth. The urinary meatus, located at the tip of the penis, serves as the external opening to the urethra. The penis is composed mostly of erectile tissue. Most of the body of the penis consists of 3 cylindrical spaces or sinuses of erectile tissue. The 2 larger ones, the corpora cavernosa, are side by side. The 3rd sinus, the corpus spongiosum, surrounds the urethra. Erection results when nerve impulses from the autonomic nervous system dilate the arteries of the penis, allowing arterial blood to flow into the erectile tissues of the organ. The scrotum is the thin-skinned sac that surrounds and protects the testes. The scrotum also acts as a climate control system for the testes, because they need to be slightly cooler than body temperature in order to allow normal sperm development. The cremaster muscles in the scrotal wall relax or contract to allow the testes to hang further from the body to cool, or to be pulled closer to the body for warmth or protection. A medial septum divides the scrotum into 2 chambers, each of which encloses a single testis. The testes are oval bodies in the size of large olives that lie in the scrotum. Usually, the left testis hangs a little bit lower than the right one. The testes has 2 functions: to produce sperm and to synthesize the testosterone hormone, which is the primary male sex hormone. Sperm is produced in the seminiferous tubules of the testes. Similar to the female reproductive system, the anterior pituitary releases gonadotropins, FSH and LH. These hormones stimulate the testes to produce testosterone, which assists in maintaining spermatogenesis, increasing sperm production by the seminiferous tubules, and stimulates production of seminal fluid. The epididymis, which lies against the testes, is a coiled tube almost 20 feet long. It collects sperm from the testes and provides the space and environment for sperm to mature. The vas deferens is a cord-like duct which transports sperm from the epididymis. One such duct travels from each testis up to the back of the prostate and then enters the urethra to form the ejaculatory ducts. Other structures, such as the blood vessels and nerves, also travel along with each vas deferens and together form the spermatocord. The urethra is the terminal duct of the reproductive and urinary systems, serving as a passageway for both semen and urine. It passes through both the prostate gland and the penis and opens to the outside. The male reproductive system also encompasses accessory glands, including the seminal vesicles, the prostate gland, and the bulbourethral glands or Cowper's glands. The seminal vesicles, which produce nutrient seminal fluid, and the prostate gland, which produces alkaline prostatic fluid, are both connected to the ejaculatory duct leading into the urethra. The paired seminal vesicles are convoluted pouch-like structures lying posterior to and at the base of the urinary bladder in front of the rectum. They secrete an alkaline fluid that contains fructose and prostaglandins. The fructose supplies energy to the sperm on its journey to meet the ovum, and the prostaglandins assist the sperm in mobility. The prostate gland lies just under the bladder in the pelvis and surrounds the middle portion of the urethra. Usually, it is the size of a walnut, but this gland enlarges with age. The prostate and seminal vesicles above it produce fluid that nourishes sperm. This fluid provides most of the volume of the semen, which is the secretion in which sperm are expelled during ejaculation. Other fluid that makes up the semen comes from the vas deferens and from the mucus glands in the head of the penis. The bulbourethral glands, or Cowper's glands, are two small structures about the size of peas, located inferior to the prostate gland. They are composed of several tubes whose epithelial linings secrete a mucus-like fluid. This fluid is released in response to sexual stimulation and lubricates the head of the penis in preparation for sexual intercourse. Regardless of the type of sexual stimulation, the physiological response in women and men is similar and usually follows a four-phase pattern, including excitement, plateau, orgasm, and resolution. During excitement, the person experiences sexual arousal with specific changes such as the erection of the penis in males. In the plateau phase, the physiological changes of the excitement level off. In the orgasm phase, the tension that is built up during the previous two phases is released. During the final phase of resolution, the body returns to the physiologic non-stimulated state. Sexual behavior involves the participation of the autonomic and somatic nerves, and the integration of numerous spinal sites in the central nervous system. The penile portion of the process that leads to erections represents only one single component. Penile erections are an integration of complex physiological processing involving the central nervous system, the peripheral nervous system, and hormonal and vascular systems. With sexual stimulation, the arteries leading to the penis dilate and increase blood flow to erectile tissues. At the same time, the erectile tissues compresses the veins of the penis, reducing blood flow away from the penis. Blood accumulates, causing the penis to swell and elongate, producing an erection. As in women, the culmination of sexual stimulation is an orgasm, which is a pleasurable feeling of physiologic and psychological release. Orgasm is accompanied by emission, which is the movement of sperm from the testes and fluids from the accessory glands into the urethra, where the sperm and fluids are mixed to form semen. As the urethra fills with semen, the base of the erect penis contracts, which increases pressure. This pressure forces the semen through the urethra to the outside in a process called ejaculation. During ejaculation, the ducts of the testes, epididymis, and vas deferens contract and cause expulsion of the sperm into the urethra, where the sperm mixes with seminal and prostatic fluids. These substances together with mucus secreted by accessory glands form the semen, which is then discharged from the urethra. Thank you for watching.